to assist the access and also to size the prosthesis. I have no disclosure for this presentation. And we know that the most common percutaneous interventional structural procedure nowadays is TAVI. So by CT, we can assess the valve morphology and anatomy. Is it bicuspid or tricuspid? The calcification of the leaflets. But does that matter actually? We know that the bicuspid actually excluded from the main trials of TAVI. But from observational study, we know that the bicuspid and tricuspid aortic valve, it has the same outcome regarding of the clinical outcome. The success of the procedure may be lower in the bicuspid aortic valve if we look for the data from old or early generation devices. But with the new generation devices, even the procedure outcome is the same for the bicuspid and tricuspid. Another study also looked for the procedure success and also the all-cause mortality and major stroke between the bicuspid and tricuspid, and there was no significant difference. The parameters actually you have to pay attention to is the calcification of the annulus and the LVOT. And why is that? Because we found that the moderate to severe calcification actually associated with complication and poor outcome in a form of more of paravalvular leak, moderate to severe, also in a form of annular rupture, of need for valve-in-valve as bailout, and in all-cause death. But the annular rupture actually it's catastrophic, and in hospital death is about 60%. But the worst annular rupture, if it is happen in the vulnerable part of the LVOT, which is between the commissure of the left and right and the mid of the left coronary cusp. Also by CT, we can assess the annulus, which is the gold standard for assessment or the choosing of the size of the device. Usually we assess the area, perimeters, and diameters. And the most important also parameter to assess the risk of the coronary artery occlusion. So we have to look to the left and right coronary height from the annulus, the sinus of Valsalva, the magic number for the height of the coronary artery, especially the left main, is 12. In some studies, it's they mention it's 10 millimeter, and for sinus of Valsalva, if it is less than 30 millimeter, the risk of occlusion is high. As we can see here, most of the occlusion happened when the left coronary artery height was less than 12, and sinus of Valsalva if it is less than 30 millimeter. Do we need to assess or look to the sinotubular junction diameter? Yes, in conjunction with the height of the sinotubular junction. And this is important when there is a short height of the sinotubular junction, especially if we are using a balloon expandable valve, because if the sinotubular junction diameter is lower or less than the device diameter, so the risk of the injury of the sinotubular junction is high. And also to predict the risk of developing of the AV conduction block, we can use the CT to predict that. We know that the presence or pre-existing right bundle branch block, the depth of the deployment of the valve, it matter, but also if we have a short a membranous septum less than 8 millimeter, it's associated with higher risk of AV block and higher permanent pacemaker insertion. Also, vascular access is very important because vascular complication associated with increased morbidity and mortality. So you have to assess the femoral artery first because it's actually now the most common access for TAVI. We assess the common femoral in a form of the height of bifurcation, calcification, especially if it is in the anterior wall, the tortuosity. If the tortuosity without calcification, usually it is easy to tackle that during the procedure, but if it is with calcification, most of the time it's associated with some difficulty and complication. If the artery is not suitable for intervention because the diameter or calcification, then you have to look for other access like the subclavian or carotid artery. Then you have to assess also the coronary artery. Unfortunately, those people with severe aortic stenosis usually have severe calcification of the coronary artery, but at least if you are able to exclude significant disease in the left main and the proximal main arteries, it will be enough to delay the diagnostic coronary angiogram until the time of the TAVI procedure. For TAV in SAV, usually, we don't need actually CT for sizing of the valve because we know the size of the surgical valve from the surgical note, and then we can go to the vendor chart and assess or detect and get the inner diameter of the prosthesis. Sometimes we don't know the size of the valve or the vendor, so then we can use CT to measure the inner diameter. The more important than that is to predict the risk of coronary obstruction. And we know that we have two main types of the surgical valves, which is stentless and stented valve. For stentless, to assess or predict the risk of obstruction, we can go through the same points that we go in a native artery by assessing the height of the coronary from the annulus and also the sinusotubular junction, sinusovasal diameter. For stented valve, we have to see the origin of the coronary artery for the left main and the RCA. If it is above the level of the post of the stents, so there is no risk of obstruction and the assessment end. But if it is below or at the level of the tip of post, then we have to assess what we call VTC, or the virtual transcatheter heart valve to coronary, which if it is less than 4 millimeter, so the risk of occlusion is high. And also I prefer to measure that also at the sites of the sinusotubular junction if the post reach the sinusotubular junction, because there is also a risk of sealing if it is less than 4 millimeter. Planning of left atrial appendage occlusion. Usually we do that with a prospective ECG trigger. In the first scan, most of the cases with atrial fibrillation, you will have this filling defect, but it doesn't mean presence of thrombus. Usually we do another scan with a delay for about 30 to 40 seconds just to rule out the thrombus. Like this case, this filling defect actually ended up with the normal left atrial appendage, but in this case, the filling defect persists and it indicates the presence of clot. Then we have to assess the left atrial appendage orifice and landing zone. And this is actually different from vendor to vendor if you are using Watchman device or Amplatzer device. You can use also the CT scan for fusion with the fluoride during the procedure, and we can see here the contour of the left atrial appendage the heart chamber, and also the interatrial septal to facilitate the puncture and also the landing zone of the device. For transcatheter mitral valve replacement, we usually use the D-shaped annulus to take the measurements for maximum and minimum diameter for trigon to trigon, commissure to commissure, and the septal to lateral. All of these, it's important to size your device, but more important than that, to predict the LVOT obstruction. And we can do that with a special software where you can virtually implant the device, and at the end of systole, you can measure the LV or the new LVOT. If it is less than 1.7 square centimeter, the risk of obstruction is high. If it's more than 2.3, risk of obstruction is unlikely. You can also predict that by using the aortomitral angle, and this is by draw a line from the center of the aortic valve, another line from the center of the mitral valve, and measure the angle between those two lines. If it is less than 90 millimeter, so risk of obstruction of LVOT is high. For transcatheter pulmonary valve replacement, also we can assess the pulmonary valve annulus, dimensions, the perimeters, and area to size the device. And also you have to pay attention to the conduit size below and above the valve, and also the length of the conduit. CTin, the tricuspid valve treatment planning. Like other valves, we can assess the perimeter, area, and diameters of the tricuspid valve to choose our device, but also more important than that, to pay attention to the right coronary artery and relation to the tricuspid annulus, because if the distance less than 2 millimeter, so injury to the RCA is high. For tric valve, also by CT, we can assess the IVC to size the device, and also the SVC. In conclusion, the CT actually, it's an important tool to plan your structural intervention and to avoid the expected complication. Thank you.
Thank you very much, Dr. Mongee. You can sit with us, Anas. So I will start, being I'm the panelist here, the question to Dr. Mongee. We noticed that for the same patient, the same cardiac CT,